Hello, everyone. Good morning, good afternoon, good evening from wherever you are listening, either live or recorded. Welcome to this webinar on mobile clinics in humanitarian settings and pharmacist contributions. My name is Ruben Viegas, and I'm the Humanitarian Sustainability Program Manager at FIP, and I'm here with all these beautiful colleagues that we'll introduce in due time to talk about mobile clinics and how these contribute to humanitarian settings and to disaster and emergency situations. So with myself, I have Pernille Miller, pharmacy coordinator in MSF, and I'll just briefly give the floor for Pernille to introduce herself.
Hello, everyone. As just mentioned, my name is Pernille, and I have worked for Médecins and Frontières for the past 10 years as a pharmacy coordinator in my last position, and I'm looking really forward to this event today and hearing from our colleagues about mobile clinics.
Thank you, Pernille. You'll be hearing more from her during the discussion as well and the Q&A that we'll have at the end. So just a few announcements before we start. This webinar is being recorded and live streamed via YouTube. The recording will then be available at our website, events.fip.org, so you can share this recording with colleagues that could not attend today. You may ask questions, use the question box provided. You can also use the chat box to say where you come from and just greet the other participants. You can provide feedback at webinars@fip.org. And also, if you're not a member, you can look at membership in our FIP webpage. There's also a new translation feature on Zoom, so you can turn on your captions and enable the translation toggle, and then you can choose your preferred language under My Caption Language, so you can follow the event with captions in your preferred language. So if you wish, this option is available. This event fits under the humanitarian program at FIP, which is one of the priority programs for 2025. We have a dedicated page that is humanitarian.fip.org, where you can find the different resources and activities that we do under this program. So if you have not visited this page yet, feel free to have a look. And also, I would like to highlight that this program links to several FIP development goals, being Goal 18, access to medicines, devices, and services, the main one. And of course, with the mobile clinics, we're improving access to these medicines, devices, and services in these difficult situations. Our program was a welcome and introduction by the moderators that we're doing now, and then we'll have 3 presentations. First one is an overview of the importance of mobile units in humanitarian settings, and that will be Marc Wilkinson that will be presenting. Then we have a bit of the regulatory aspects of mobile units, so we can understand what are the requirements in case you're interested in getting more involved. And then we have a case study, an example from Japan with the deployment and operations of a mobile pharmacy unit following the 2024 Noto Peninsula earthquake. So the second presentation will be Gino Philip, and the third one will be Takashi Egawa. So they will be doing these 3 presentations, and then we'll have a Q&A session afterwards. And briefly, we will do a wrap-up in conclusion within these 90 minutes that we have for this session today. Learning objectives for the session are to understand the structure, function, and operational challenges of mobile pharmacy clinics in humanitarian and underserved settings, recognize the critical role of pharmacists in delivering essential healthcare services through mobile platforms, and also identify key regulatory considerations influencing the operation of mobile pharmacy clinics. And now I'll hand the floor to Pernille for the presentations, and then we'll move forward with the presentations themselves. Thank you so much.
And our first speaker today will be Marc Wilkinson, who works for Médecins Sans Frontières as a pharmacy coordinator. I will leave the floor for Marc.
Good morning, good afternoon, everybody. Can you all hear me okay? Perfect. So yeah, as was mentioned, my name is Marc Wilkinson. I've been working with Médecins Sans Frontières for the last 8 years now, maybe 9. So I've just recently ended my position as the General Assembly representative for the UK. So whereas I was working on a lot of things like mobile clinics when I first started in the organisation, I've now kind of got more into the governance and organisation of how do we actually put in place these kind of interventions in order to support our colleagues and patients around the world. So as the first speaker, I guess it's kind of on me to just give a very brief overview of our organisation and then how we tie into the use and implementation of mobile clinics, but also what those mobile clinics are capable of and how they can benefit the patients, alongside some of the challenges that we face when we're working in locations that are often more rural, harder to reach, and the logistical and pharmaceutical challenges that that poses. So I'm sure, Ruben, if you could go to the next slide, please. So we are MSF, Médecins Sans Frontières, Doctors Without Borders, Arts and Underground. So wherever you are in the world, we've got some kind of acronym to explain who we are and what we do. And essentially what we're trying to do is provide medical aid in places that would otherwise not be able to account for its own citizens within a particular time frame. So that could be long-standing due to conflict or political turbulence, or that might be in the very short term as a response to natural disasters, so tsunamis, earthquakes, that kind of thing. Next slide, please. So our aim is to maintain independence, neutrality, and impartiality. And a large part of the draw of what brings people to MSF is that we are funded by private donors. We don't have any allegiance or affiliation to international or government organisations. So we've quite famously several years ago refused funding from the European Union in order to maintain our independence so that we could continue to provide care and search and rescue operations for migrants crossing from, at that time, predominantly Libya into the Mediterranean and across to Italy and Greece. So a lot of our typical responses are things like we have in this picture here, which would be a response to Ebola. So this was in the DRC a couple of years ago when I was working there. Next slide, please. So a huge part of where we get involved in the mobile clinics is doing nutrition assessment. So this is an example of one of our colleagues in the Central African Republic using the MUAC bands. So some of you may be aware of these. So it's a really quick and simple way to assess the nutrition, malnutrition of particularly young patients. And we can use that to not only treat the patients in front of us, but to map the numbers of people coming through, where they might be migrating to and from, in order to better understand the picture of how we can plan and organise interventions within a particular area. Next slide, please. And then in this particular example, we're responding to direct threats and having to move around from different areas. So this image is actually taken in Gaza. So we have some colleagues there providing aid almost on the street with very limited supplies to patients that are obviously victims of man-made disasters. And next slide, please. And here we also do a lot of advocacy. So we work towards patient rights, trying to reduce the cost, so that when we're doing interventions like mobile clinics, so in certain places like the DRC, Democratic Republic of Congo, where we've been able to advocate drug companies to reduce their prices of tuberculosis and HIV testing, we can then start to introduce this into our mobile clinics, TB screening. And then because we've been able to push down the price, the local Ministry of Health is now in a position in certain districts to take over the tuberculosis care. So it's almost that handover process of being able to advocate for cheaper supplies, putting them into our mobile clinics and using those mobile clinics as almost a training and implementation tool to allow the local Ministry of Health to take over and increase their capacity. So next slide, please. So what are mobile units there for? I guess the easiest way is to try and think of it as a way of bridging the gap in many senses. So this is not always the case. Sometimes it's a case of it's just easier, but the majority of the time we're responding to some kind of disaster, whether that's natural or man-made. typically with the increase in climate change and population movement in equatorial regions. Obviously, you can have an argument whether it's certainly man-made, but it's climate-driven. And the causes of those movements and the reasons that we need to implement a mobile clinic in particular scenarios is that we see displacement of potentially millions of people where the infrastructure in terms of roads, road networks, rail, air is completely destroyed or overwhelmed. And mobile units provide a responsive method of delivering healthcare to communities in need very rapidly and quite flexibly. Now, obviously, we have challenges in relation to the access and the security and displacement of these areas. But it does allow for an initial response and I think a lot of the time showing people that they are not alone, particularly people who have been driven from very, very stressful. There's been some fantastic research recently, particularly relating to elderly patients who are often forgotten in the humanitarian world, and just showing up to places where they are and offering some support can be a huge psychological relief for patients in their particular situations. Next slide, please. So what are health units and what do they look like? So they can be very different. So we can have on the left there sort of textbook image of a tent that's been popped up and we're doing very simple things, maybe some quick assessments, respiratory assessments, offering antibiotics for a chest infection, offering some zinc and some oral rehydration salts for a child with diarrhea. But we can also do a little bit more complicated things. So we can set up sort of semi-permanent structures. So although these still might come under the remit of mobile clinics, they might be empty most of the time or used for another purpose. And we will reach a location, maybe even once a week, twice a week, and use that location as a temporary structure to be able to deliver care. So in this particular situation, it was a school that was in the Central African Republic that we used as a temporary base twice a week to provide some care. And then the third image on the right shows an image in the Ukraine. So this was in the early parts of the war with Russia. And so to get away from that kind of typical view that we have of being in a dusty, hot equatorial environment, it's just a reminder that we are operating in lots of different places. We can have, so in this particular truck here, we had mental health support for victims of the violence and the fighting in the Ukraine. So next slide, please. I'm just conscious of time and letting the others speak. So just to highlight what we can do in a tent. So this is often sort of what's presumed, that we don't have the facilities, we don't have the infrastructure. And in the mobile clinics, it all depends on the staff that we have, the equipment that we have available. So we can do simple surgery like cesareans, deliver children in small, pretty, what would otherwise seem to be inhospitable little areas. We can do very simple things like create remote posts. So we have within MSF, particularly in certain regions that are very susceptible to malaria, we have a sort of structure where we will have a hospital that will filter down to a health centre, that will filter down to a health point, where they will do very simple interventions, all the way down to single disease posts, where we might just have one person sat there doing malaria tests. If that person tests positive, we give the treatment out immediately. And that rapid access to treatment, when we look in particularly areas like the Central African Republic, where up to 100% of the population get malaria every year. So I think we give out more than 5 million malaria treatments a year in a population of about 4.7 million. So some people are getting it twice a year. So that rapid access is really important. In places like the Philippines, we offer chest x-rays. So this is part of the tuberculosis treatment pathway. So this is to identify drug-resistant and extremely drug-resistant tuberculosis, often in urban areas as well as rural areas. So we're targeting certain locations within cities where we see a ring or a spike in tuberculosis cases. We can go out and do x-rays, do the rapid action testing, and then start putting people on the treatment that they need to prevent the spread of tuberculosis, when we know that tuberculosis is probably going to be the world's biggest killer in the next 20 or 30 years. I think it's 40 million people a year are dying of tuberculosis. So by providing those points and getting in there really quick is really, really important. And then next slide, please. So obviously providing healthcare in remote settings is obviously very challenging. So if we look at the logistics there, we're seeing that crossing roads, rivers, bridges that are susceptible to the natural elements is obviously very tricky, as is maintaining a cold chain. So technology is really starting to help us there. So we're seeing more solar-powered cold chains, things that can be battery reheated. We're getting all sorts of new technology that's really exciting, that's allowing us to deliver vaccines and insulin into areas that was otherwise very challenging. So we're seeing real technological interventions there. But the old issues of flying into places when it's too hot, too wet, too cold, too dry, too dusty, they're always going to be part of the issue. And then next slide, please. And then we also have to be careful of our cultural sensitivity and maintaining good relations with the community. So obviously, if we're a mobile clinic, we are turning up into the area, into the community of other people. And we've seen in certain situations where either our equipment and buses have been targeted, facilities have been burnt down or attacked. It's quite rare, because we do a reasonably good job of trying to integrate with communities, but we can always do better. But being able to communicate and listen to the communities, find out what they want from a potential treatment, not turning up and going, we know best, this is our plan. And this is something that typically when I've got a bit more time, I will talk about for 15, 20 minutes just as its own topic, because it's so important. And I think generally speaking, aid organisations aren't great at this. So it's so important that we bring the community along and also allow the community to lead in our activities. And next slide, please. And then our pharmaceutical challenges. So a huge part of the pharmacist job, I'm sure some of the others will come on to, is about forecasting, ensuring rational usage of medications, auditing, making sure that the medications we have are being used correctly, they're not being wasted. Because particularly in MSF, when I've worked in certain contexts, in Myanmar, for example, I might place an order and my medication might not arrive for 6 to 8 months. So I've got to plan ahead. So I need to make sure that we're using things correctly, safely. In areas where we have very little stock, there's often rats running around, we're having stock being eaten by animals and vermin. The temperature is very, very often above 30 degrees, and we don't always have air conditioning to maintain the integrity of those medicines. So it's a huge range of challenges that I'm sure some of the others will go on to. So I'll stop there. So just onto the final slide. So just to very quickly sum up this brief introduction into mobile clinics. And just tap one more time. So mobile clinics should be flexible, adaptable, and multidisciplinary, and dictated by the local need, implemented with community involvement. And the most important thing is we need more pharmacists in the humanitarian sphere. There are not enough of us. We make such a big impact. A good pharmacist in a project can reduce costs, can pay for themselves, can pay for others to be upskilled, create packages and pathways and protocols that will genuinely save lives, improve and streamline workflow, and enhance medicine's quality and management in low and middle income settings. And I always love to put this picture in because it's my favorite picture. I have it on my home wall. So this is with my team from Boston Going, my first project 8 years ago. And it always makes me smile because I still speak to many of my former colleagues now. And it highlights the importance and what a difference we can make, not only to the sort of humanitarian sphere, but to yourself as an individual by getting involved in this. So I hope between the speakers today, we can convince a few of you to join the cause and come be a humanitarian pharmacist alongside us. So I will stop there. And if you have any questions later, I'm more than happy to answer. Thank you.
Thank you so much. This was really very, very inspiring, and I hope everyone got something out of it. Just before we move on, if you have any questions, you're welcome to already now put them in the Q&A of the chat. And otherwise, just put your hand up when we come to the end, and then our speakers will take questions. And the next speaker we have is Jinu, who works for Wilkinson in the US, and he has a very interesting presentation as well. I leave the floor for you, Jinu.
Good afternoon, good morning, good evening, wherever everyone is. My name is Janu Phillip, Director of Pharmacy Affairs for Walgreens. I cover Walgreens on the regulatory team here. I cover about 1/3 of the country, mostly the east and southeast of the United States. And my role is to assist in anything dealing with Board of Pharmacy laws and rules. And then with it, because I cover most of the southeast, that is typically where we generally see, most of the hurricanes in the United States. And so as a result, I have sort of become, the sort of the expert on how to address getting mobile pharmacies up and running on the regulatory side. If we can go to the next slide. Ruben, let me know if you're able to get that. Next slide. Thank you. And so this is, you guys just saw the video of Hurricane Helene passing through one of our stores in Asheville, North Carolina. And this is the aftermath in terms of what our location looked like. The location itself is currently still inoperable. So as a result, you can see the Lowe's in the background, and that is there's actually a mini shopping mall that's in there called the Asheville Shopping Mall, and so the decision was made to leverage a mobile pharmacy. Emergency mobile pharmacy in the parking lot of that Lowe's. And so if you can, so with Hurricane Helene, it brought catastrophic flooding to Western North Carolina, isolating entire communities. Roads and bridges were washed out, power grids failed. So in Asheville and the surrounding areas, water treatment facilities also were severely damaged. It left thousands without access to clean water for days or even weeks. The storm's aftermath left homes submerged, phone lines down, critical infrastructure inoperable, creating a public health emergency across the entire region. From a patient impact standpoint, patients with chronic conditions were suddenly cut off from their medications, providers, and even basic necessities. So with pharmacies closed and transportation routes blocked, many residents had no way to get their prescriptions or receive urgent care. Pretty much every pharmacy in that area was impacted and unable to open. And so the emotional toll was pretty severe. Patients faced a lot of stress, anxiety, and isolation, and really struggled managing their complex health needs. So this is why Walgreens Emergency Mobile Pharmacy mattered so much. In the midst of the chaos, the rapid deployment of our emergency mobile pharmacy provided a lifeline, restoring access to medications, immunizations, and a sense of normalcy. Our presence not only filled a critical healthcare gap, but also a place of connection and reassurance for community in crisis. I do have a few pictures I'd like to share. So next slide. So this is the site selection. Again, so you sort of saw the Lowe's in the background, but we decided to move the pharmacy really less than about half a mile from the location, and you can see where we decided to place the unit relative to where our existing location was. Next slide, Ruben. This is the parking lot itself. So we placed the mobile pharmacy within the parking lot. They designated the owners of the mall designated where we were allowed to put it, and we went through the different steps of getting it set up. Next slide. So we'll kind of walk through this key steps we took to get the emergency mobile pharmacy set up and running in Asheville. We started with the special use permit, and this was submitted online, and the approval came through pretty quickly, typically within the same day. To get that permit, we had to provide a site plan, blueprints of the trailer, a photo of the trailer, and detailed description, including plumbing and power sources. Now, while the trailer was placed on site without the permit, we couldn't begin operations until that permit was officially approved. Once that was in place, we moved on to get the electrical permit, which we could apply only for after the special use permit was approved. As it relates to the fire marshal, no permit was required, but we did need to ensure that the proper interior exit signage was installed. Next came coordination with the Board of Pharmacy in North Carolina, as well as the DEA, in order to procure and dispense controlled substances. Our team coordinated with efforts to notify both agencies. The Board of Pharmacy director, who I have a good relationship with, approved the EMP without any issues. The DEA process, however, was a bit more complex because the EMP was located at a different address than the one listed on our DEA license. So we had to jump through a few additional hoops. So normally updating an address with the DEA can take months, but thanks to the efforts of our licensing team, we were able to get the address updated the very same day. So with that, it allowed our wholesaler to proceed with ordering controlled substances, and we received approval to dispense those medications directly from the mobile pharmacy. Next slide. So now we'll talk about infrastructure setup for the mobile pharmacy. For electrical setup, Duke Energy played a role in assisting with the installation of the power pole, which was completed within a week. In the meantime, the trailer operated on generator power until we could transition to shore power. On the IT and connectivity side, we didn't have any cabling running to the trailer, so we had to explore alternative options to ensure that we had reliable network access, as that was critical to network speed to meet our operational needs. We also arranged for essential service providers to support the site, and that includes sanitation services, water supply, and regular generator fueling to keep everything running smoothly. All right, next slide, Ruben. So this is a trailer of the back of the unit. You can see the generators installed on the back, the HVAC units. Next slide. This is a picture of the front of the unit, and see the barriers there as well. All right, and so moving on to equipment and logistics, these were essential to get the EMP fully operational. We started with signage. It was ordered from the local sign shop. For waste management, we utilized the mall's existing dumpster and cardboard services to help streamline the setup without needing additional vendors. In terms of security, we conducted an assessment to determine whether security guards would be necessary for the site. We decided guards were not necessary at this site, although we have used them in other locations. In terms of power, the EMP trailer came equipped with a 175-gallon generator as backup. We also arranged for an auxiliary generator service to refuel every 3 days to ensure continuous operation. We also had safes in place, and this is both for Schedule II narcotics as well as a cash safe, and we made sure everything was functioning properly. Refrigeration obviously is critical for storing refrigerated and frozen medication, so we confirmed that the fridge and freezer temperatures were within the required range, and we ordered additional units just in case. For furniture and storage, we had everything delivered, including tables, chairs, storage pod, and barriers to help with organizing the space. And then finally, we ensured the accessibility by confirming that the wheelchair lift was fully operational, and that was necessary for actually passing the final inspection. Next slide. This is a picture of the interior of the space to give you an idea, just the hallway. Next slide. So before we could officially open the emergency mobile pharmacy, we had to complete a series of inspections, and these were essential to ensure compliance and safety. We also had to make sure that everything was in place prior to the launch. On the IT and AV setup, we ensured all the equipment, the PCs, the registers, the printers, the phones, they were all fully operational and functional. We also tested our AV and alarm systems to confirm everything was working as expected. For banking and cash management, we updated our address and coordinated with the nearby store to borrow cash temporarily until the formal bank order actually arrived. And in terms of supplies and inventory, we received both regular and control medication with additional orders placed as necessary to maintain the stock. And then lastly, we made sure all of the emergency equipment was delivered, including backup systems, as well as the DPI disposal bins, so we were fully prepared for any situation. Next slide. So this gives you sort of a timeline. Day one for us was October 14th. That was the day the trailer arrived at the Asheville Mall. We powered it up, set up the alarm systems, placed an expense order, and that was scheduled to arrive later in the week. The following day, that's when the generator arrived, and then we had an auxiliary generator initially just to run until the full generator could get set up. Again, we had the refueling service every 3 days. On day three, we worked with Duke Energy on 2 service applications, and one was for the mall, the other was for the store parking lot. We also received other supplies such as a tent, the porta-johns, washing stations, and then finally, all the IT checks were completed. We also confirmed that the wheelchair ramp was operational, and we delivered all the like the smart sensors for temperature monitoring, as well as other devices internally, including the shredded bins, which was used for DPI. The following day, which is Thursday, is when we received all the expense items. On Friday, the signage kit arrived along with the first order of prescription drugs. We used the Saturday to go ahead and set up, and then on that Sunday we did a soft opening of the trailer to make sure everything was functioning properly and minimize any hiccups before we go fully live on that Monday. So we keep in mind that the storm hit right at the end of September. I think it was September 28th or so. And so we were able to get the trailer installed within pretty much a 2-week period, and then opened within a week after that. So I think it was pretty impressive in terms of what we were able to accomplish in such a short amount of time. Next slide. So once we opened, so this gives you a picture of, internally what it looks like. This is that hallway. You see the wheelchair lift in the back, the waiting area for the patients to sit in. We have the pretty much a standard pharmacy from a viewpoint when you look at it in terms of the ability to dispense and fill prescriptions. Next slide. Picture of the pharmacy inventory. If you notice the rollaway carts that we utilize there. And in terms of as we approach the final stages of setup, we focused on IT connectivity. That ensured all the PCs, registers, printers, phones, everything was working properly. We had IT technicians both on site as well as working remotely to assist with that. We also had contingency plans for internet connectivity, and so we had a special phone line set up for those to contact if internet went down. We also utilized smart sensors to monitor temperatures, and HVAC cooling concerns were definitely present during the initial days, especially since we had some higher than normal temperatures. But luckily, we were able to see those temperatures return back to normal very quickly. And then obviously internally, we had to ensure that the fridge and the freezer had maximum alert threshold set. And so this way, if any of those temperatures were exceeded, we would be notified and troubleshoot right away. We also had to make sure portable restrooms and washing stations were set up because of compliance reasons. And then for security and compliance, the pharmacy manager at the location submitted internal tickets for both C2 as well as cash saves. Next slide. In terms of community impact, once we did open, we were able to begin immunizations right away to help reduce some of the wait times. We initially set up a tent outside the trailer, and one of the most critical vaccines we administered was DTaP, and obviously with with the risk of tetanus in the area, that was especially needed in the community at the time. We also implemented a triage system using walkie-talkies and pharmacy employees acting as runners to go between the tent and inside to minimize or to streamline patient flow and improve efficiency. We also utilized emergency refill provisions to ensure patients could access their medications quickly, even if they had lost everything in the flooding. Many patients didn't necessarily use Walgreens, and we were able to still leverage emergency refill provisions to ensure that those patients were able to get their prescriptions. In many cases, we were unable to reach prescribers, and all we were able to have was information that patients were able to provide, and we were able to use that to go ahead and refill their prescriptions. The response from the community was actually pretty incredible. Patients were genuinely grateful that we were able to open so quickly. And just beyond providing care, our location really became a hub for connection. It was about the only thing open, so quickly after the hurricane had hit. And it was a place where people could come together, share their experiences, and feel supported during a really difficult time. And with that, I think that'll conclude it, and I'll I guess ask for questions at the end. Thank you.
Thank you so much, Janine. This was really inspiring to see a mobile clinic in a completely other setting than what we heard from Marc. And thank you for the questions that we have already received. We will take them in the end. Yeah. And our last speaker today is Takashi. And I'm looking forward to hearing your experience with the mobile clinic. I leave the floor for Takashi.
Hi, thank you. Good morning and good afternoon and good evening, everyone. My name is Takashi Egawa, and I'm a pharmacist and professor at Fukuoka University in Japan. I belong to the Japan Medical Team for Disaster Relief, we called JDR. And I have participated in multiple disaster relief missions, including in Nepal in 2015 and Myanmar in 2025. Today, I would like to share the pharmaceutical activities carried out during the response to the 2024 Noto Peninsula earthquake. Next slide, please. Over the past decade, I have participated in various disaster and conflict response missions, both on-site and through off-site support from Japan. Most recently, I was deployed to Myanmar in 2025 following the major earthquake and to the Noto Peninsula earthquake in 2024. I have also contributed to offsite support for the Gaza conflict and the Turkey-Syria earthquake, coordinating pharmaceutical logistics and technical assistance from Japan. In 2022, I was involved in emergency support activities in Moldova related to the Russia-Ukraine conflict. During the COVID-19 pandemic, I supported medical and pharmaceutical operations in Japan from 2020 to 2022. My earlier deployment included the 2015 Nepal earthquake, the 2016 Kumamoto earthquake, and the 2011 Great East Japan earthquake, where I engaged in pharmaceutical supply and public health coordination. These experiences have shaped my approach to the disaster pharmacy and strengthened international collaboration. Next slide, please. Okay. The Noto Peninsula earthquake, which occurred on January 1st, had a magnitude of 7.6. It was the largest record earthquake in the Noto region since record began in 1885. The earthquake caused significant damage to pharmaceutical infrastructure. A total of 44 community pharmacies were damaged, and 3 of them were forced to cease operation. In Ishikawa Prefecture, 197 evacuation centers were set up to accommodate disaster victims, and over 2,200 people were displaced. Next slide, please. When a disaster strike, the Japan Pharmaceutical Association established the disaster response headquarters to collect and centralize the information. The Disaster Response Committee coordinated the deployment of disaster relief pharmacists to affected areas in collaboration with local pharmaceutical associations, such as Ishikawa Pharmaceutical Association in this case. In addition to human resource, they dispatch mobile pharmacies, which specially equipped a vehicle designed to provide medicine during an emergency. These vehicles contain dispensing equipment and essential for continuing pharmaceutical service in affected regions. In the 2024 Noto Peninsula earthquake, disaster relief pharmacists offered dispensing service at mobile and temporary pharmacies in Suzu, Wajima, Monzen, Anamizu, and Ushizu. They also provided health consultation on board a ship that was offering bathing service to disaster victims at Nanao Port. Furthermore, they were engaged to public health activities at evacuation centers throughout the Noto Peninsula. Next slide, please. During the 2024 Noto Peninsula earthquake, a total of 14 mobile pharmacies from 13 regions across Japan were deployed to the affected area. These units were stationed at 5 medical relief points throughout the Noto Peninsula, enabling large-scale and contributed to pharmaceutical response. In addition, pharmacists conducted health consultation on board a ferry docked at Nanao Port, which was providing bathing service for disaster victims. This multi-site deployment demonstrated the flexibility and scalability of mobile pharmacies in large-scale disaster. Next slide, please. This slide shows the pharmacists play an essential role in disaster relief by operating temporary pharmacies set up near medical relief posts. At these locations, they were responsible for dispensing a medication, maintaining proper drug management, and ensuring the continuity of pharmaceutical care for patients affected by the disaster. Additionally, in evacuation shelter, pharmacists monitored indoor carbon dioxide levels and provided guidance on adequate ventilation to support public health. Next slide, please. The mobile pharmacy was deployed by the Miyagi Pharmaceutical Association based on the lesson learned from the Great East Japan earthquake in 2011. It is a self-sufficient medical support vehicle capable of providing standard dispensing and pharmaceutical supply, even in disaster scenario where lifelines such as electricity and water are available. The mobile pharmacy is equipped to function independently at disaster sites, supporting affected communities with essential medication. As of today, about 20 mobile pharmacy units have been deployed across Japan. These are operated by local pharmaceutical association, pharmacy university, and private company, and have been used in multiple disasters. Next slide, please. This slide shows the geographical distribution of mobile pharmacy units across Japan. Some prefectures own more than one unit, depending on their regional disaster risk and operational needs. In most cases, these vehicles are owned and maintained by local pharmaceutical associations, which were responsible for deploying them during disaster. This decentralized ownership allowed for regionally trained disaster preparedness and faster response times. Next slide, please. The mobile pharmacy is built on the Toyota Camroad 4WD diesel turbo chassis, accommodating these passengers and equipped with essential amenities, including washroom, cassette toilet, shower, and 2 beds. It indicates a 46-liter water tank and 24-liter water heater and FF heater, room air conditioner, and lighting for both indoor and outdoor use. Next slide, please. For power supply, it features a portable 1,600 watt gasoline generator, a solar panel system, and deep cycle batteries, ensuring operation even in lifeline disrupted areas. Communication equipments include digital radios, satellite phone. Some mobile pharmacies have Starlink and 14-inch television with terrestrial and satellite state satellite reception. Next slide, please. Pharmaceutical functions are supported by a battery power electric scale, automatic powder packager, tablet storage shelves, dispensing sink, and refrigerate unit. It also contains a working PC, printer desk, and sufficient space for scale and accurate medication preparation in disaster setting. Next slide, please. Mobile pharmacy play several key roles in disaster-affected region. First, they serve as stationary temporary pharmacies based at local disaster coordination centers or in communities where normal health care infrastructure has collapsed. In this role, they respond to disaster prescriptions issued by relief team. Second, they function as mobile temporary pharmacies, traveling with mobile medical units to provide on-site dispensing service during outreach activities. Third, mobile pharmacies serve as community health support units, visiting evacuation center to conduct health consultation and public health interventions for evacuees. This flexible operation structure allows mobile pharmacies to adapt to the changing needs of disaster-stricken communities. So, the operation of mobile pharmacy in disaster area can be divided into three phases. In step one, during the acute phase, the mobile pharmacy is installed next to the relief post, such as in Suzu City during the 2024 Noto Peninsula earthquake. It functions as a temporary dispensing site, accepting disaster prescriptions and initially serving as a centralizing a medication stockpile. Next slide, please. In step one, during the acute phase of the 2024 Noto Peninsula earthquake, a mobile pharmacy was installed next to the medical relief post in Suzu City. It functioned as a temporary dispensing facility, responding to disaster prescriptions issued by relief team. In addition, the vehicle served as an initial medication supply base, supporting early pharmaceutical logistics when infrastructure was severely damaged. Next slide, please. In step two, during subacute phase, the mobile pharmacy accompanied mobile relief team to regions where infrastructure is still not restored. For example, in the 2020 Kumamoto flood disaster, it functioned as a mobile pharmacy supplying a medication directly in the field. Next slide, please. This slide shows the step two. During the 2020 July heavy rain disaster, a mobile pharmacy was deployed to Kumamura in Kumamoto Prefecture. It accompanied medical relief teams to affected areas where infrastructure had been severely damaged. The mobile pharmacy functioned as a mobile temporary pharmacy, responding to disaster prescriptions issued by medical teams in the field. This operation allowed timely access to essential medication, even in remote and isolated communities. Next slide, please. In step 3, during the recovery phase, the mobile pharmacy transition to public health support. It visit evacuation center, conduct health consultation, and assist with sanitary condition assessment. An example of this is from Hita City after the 2017 Northern Kyushu heavy rain. Eventually, the mobile pharmacy prepared for withdrawal and smooth transition back to the regular healthcare system. Next slide, please. This slide shows the step 3. During the recovery phase of the 2017 Northern Kyushu heavy rain disaster, the mobile pharmacy team was deployed in Hita City. Over a period of 4 days, the team visited 5 evacuation centers and conducted 65 health consultations. The mobile pharmacy functioned as a community health support unit, addressing the health concerns of evacuees and contributing to public health efforts during the post-disaster phase. Next slide, please. In summary, mobile pharmacy have a problem to be versatile reliever tool in disaster response. Their ability to quickly begin pharmaceutical operation, support mobile clinic, and ensure the cold chain for critical medication, even without electricity, makes them particularly valuable in hard-hit areas. Additionally, their dual role of housing for pharmacies and a storage unit improve operational efficiency. However, challenges remain, such as limitations on the type of prescription they can fill, and the high cost of maintaining these costs when they are not in use. Addressing their issues will be key to the sustainable integration of mobile pharmacy into national disaster preparedness system. Next slide. Thank you for attending.
Thank you so much, Takashi. It was really, really interesting and to see how you do this in Japan. Really, thank you so much for this. And thank you for everyone for the questions already added to the Q&A. You are welcome to put in more questions or raise your hand if you have any questions. But before we go to that, I have a question for all of our panelists. And it might be a little leading questions, but as we are only pharmacists, I think it's okay. I would like to hear from you why you think it's so important that we have pharmacists involved in these mobile clinics or emergency settings. Could it not be done without a pharmacist? And I think we can start with Marc and then go, to Shinun and Takashi afterwards.
Yeah, so I think the day-to-day running doesn't require pharmacy input, but the setup and maintenance absolutely does. The challenge when working with medics is that medics want everything and they want it yesterday. And the challenge of working with logisticians is that they don't understand what any of the equipment that the medics are asking for does or is used for, or if it even is important. So the pharmacist is often the voice of reason, the voice of pragmatism. So you will have, for example, and I've seen this many times in mobile clinics, where a midwife will want to implement some new strategy for birthing of mothers, but that midwife will only be in the project for 3 or 4 months. And by the time the equipment arrives, we have a different midwife who has a different vision for how to implement these strategies. So the pharmacist is there to go, okay, but we're not going to change this unless there's really strong evidence, really strong guidance, and you've created a long-term plan that this is how we're going to do things. And that's just one example. I could go on and on and on for hours about the strange and bizarre requests I've received, but being able to make really clear decisions, doing things that are right based on input from the epidemiologist, from the medics, from the nurses, from the community. It's really important to be that focal point and the decision maker and a leader in medicines management in many of these settings. So yeah, we're absolutely essential.
Thank you, Marc. And you, Jenna?
Yeah, in the US, you know, the EMPs, the mobile pharmacies, serve as pharmacies. They're actually that's pretty much the only service that we're providing. You know, it's either pharmacy prescription dispensing as well as pharmacy services, patient counseling, immunizations, and other medication related services. So the, you know, the concept of not having a pharmacist there, we wouldn't be able to operate. So we have to have a pharmacist in order to have a pharmacy. They take the mobile pharmacy actually takes the permit of the location where that is closed. So they have the exact same permit and they have all of the same requirements that they need to meet.
Takashi?
Okay. Oh, wait. So, Japan Pharmaceutical Associations prepared a disaster response manual. It is including some plan for mobile pharmacy. So I mentioned earlier the step 1 and step 2, step 3 like this. Thank you.
Thank you. We have like 10 questions in the chat, and I think some of them were answered, but I don't know. I have a question from Vivek. Do you want to say it out loud, or should I just read it out? Okay, I will read it out. The question is that in humanitarian settings where mobile clinics operate with limited medical infrastructure, how can pharmacists ensure continuity of pharmaceutical care, especially for patients with chronic conditions who may have inconsistent access to medication? I don't know if Takashi or Marc would like to answer this question.
Nowadays, in Japan, government allowed the pharmaceutical coordinator. So like this, medical coordinator support the pharmaceutical care, who is pharmaceutical coordinator. Yes. So we tried some training for the pharmaceutical coordinator all over the world, all over the Japan now. Yes.
And Marc?
Yeah, I guess, I mean, it depends what kind of chronic conditions we're talking about. So in some contexts, we might have access to a very limited supply or a very limited number of different medications to treat epilepsy, for example, because we know that could be a life-limiting and severely impactful condition in certain areas. And at certain times, we can get a trickling supply and make sure that patients can receive these kind of things. In other contexts, and again, it can depend when we think about treatments for diabetes or high blood pressure. This can be quite controversial because my personal opinion is that an organization like MSF that is responding to emergencies primarily, we should not be providing treatments for high blood pressure or type 2 diabetes, certainly. Insulin for type 1, I agree with. But type 2, I don't think we should be, because what ends up happening is we end up overtaking local infrastructure and taking away from all those existing markets and opportunities for local economies to create their own solutions. We take that away. And likewise, when we look at, in particular, obviously I'm British, in the UK, even with extremely heavy interventions where we push and push and push patients to take their medication correctly, the adherence to medication for high blood pressure, for diabetes, is less than 30% of patients taking the medication as they should be. And then if we start doing that in contexts where the temperature is very up and down, people are working manual labor, subsistence farming, they're dehydrated for large parts of the day, giving them medications like ACE inhibitors is probably more dangerous than not giving them any treatment for a slightly raised blood pressure. And that is part of a lot of the work that's being undertaken now with places like HelpAge International and some of the collaborative work that I'm certainly looking to get involved with in investigating whether these kind of interventions are actually of any benefit. So it depends is the quick way of saying that long answer.
Thank you so much. So the next question is for all three of you. There's a question stating mobile pharmacy can be set up in response to different situations. However, different situation may need different kind of medication in store. So how do you decide or know in advance what medications the mobile pharmacy should have? Any medication list, or just depends mission by mission?
I can go first. Yeah, and in the US, we pretty much stock in a mobile pharmacy the same medications that we would in any normal pharmacy. So there's a standard drug order that we would get in. If patients are on specific medications that we do not currently have in stock, we can order them, and usually we get that the very next day. So so we don't have special lists for the mobile pharmacies. We just use in stock what we normally have in all of our pharmacies.
Other one to one,
so we are preparing a list of medication for disasters. Pharmacies provide a first-line drug suggestions to physicians. So Japan Pharmaceutical Associations prepare the medication list. And wait. Yes, sure. Thank you.
Marc, I don't know if you have anything to add to what has been said.
No, not really. Again, it depends. And I think, again, the key point of the pharmacist is you are that point who gets to make the decision. So if the doctors want 100 medicines for 100 conditions, you have to go, no, the epidemiologist is saying this is what cases are showing, this is what we think is going to happen, and cut that list down and make it as simple and as open for people with limited training to use.
And now you can stay, because I have a question I think you would like to answer. There's a question on how does one get involved in humanitarian action as a pharmacist, particularly on an international level?
Yes, I mean, it is really hard to make those first steps. I think what's important is doing things on a local level, showing that you care about people and that you've got the right attitude to want to make a difference. Depending on where in the world this person's located, there's different options. So before I joined MSF, so there's some sort of criteria that you have to join MSF. Before I did that, I worked with some homeless charities back in the UK, helped in some organisations that provide clothing and food and logistical support for asylum seekers and refugees, and then just did little bits like this to just try and get a little bit of experience in the humanitarian sector. And then once you make that, it is always harder to just make the little crack in the door. But once you've got that door open, there's huge opportunities. Some of the best opportunities and the most exciting things that have happened in my life have happened because of the humanitarian world. So the most important thing I would say is don't give up, keep pushing, apply for everything, and you will get an opportunity at some stage. Just show how much you care and how positive a person you are.
Thank you. And Takati?
I'd like to mention that it is one of the pharmacy's abilities to make suggesting from the limited list of medicines. I think so. Thank you.
Thank you. The next question I think is for you, Janun. It's is there any special legal frameworks for mobile pharmacy in the US and what WHO recommends?
Yeah, I can't really speak to what WHO recommends, but in terms of the legal framework, it would require approval depending on the state that you're in. So you need to get approval from that respective board of pharmacy to be able to operate a mobile pharmacy outside of outside of the pharmacy that was already previously permitted. So in some cases, if we've had experience in a particular state and the board knows what we currently do, we don't need any special inspections or anything like that. If it's going to be the first time that we've ever operated in a particular state, we likely would need for an inspector to come in on site. As an example, we have all the hurricanes that happen in the southeast, but we had flooding last year in Vermont. And so that was one of the states that is not used to having mobile pharmacies. And so when we installed one, the state required that they send an inspector out before we opened to ensure that it was in good working order. And for dispensing controlled substances, we talked about, we have to get special approval to dispense controlled substances from the DEA. There's a very standard way to do that, and so we just submit that request. The only problem is if you try to operate the mobile pharmacy in a different address than the one that's on the permit itself.
Thank you. I also have a question from Omar, who's asking if it's allowed for pharmacists in, I think, mobile clinic to therapeutically interchange if the medication prescribed is out of stock.
No, I do not believe it is. I don't have the laws and rules in North Carolina right in front of me, but there are very few states in the U.S. that allow for therapeutic interchanges by pharmacists. So that's in most states that would require a law change. It would require that the state approve that from a statute standpoint. And so most states have not gone that route of allowing pharmacists to do therapeutic interchanges.
Yeah, thank you. And then I have another one who reminds a bit of one I had myself, is like, for how long does it take you to set up a mobile clinic from you have decided? I know that you, Janine, said you had like a schedule you had the truck of 8 days, but I don't know how long does it take from you've made the decision we need to have a mobile pharmacy or mobile clinic to you actually are able to operate.
Yeah, the decision to move the trailer in occurred pretty much. So we were mobilizing the mobile pharmacies when we saw the hurricane actually coming to the southeast. And so even before the storm hit, we were preparing those mobile pharmacies to be moved. I think they initially started in Texas, so they had to be routed from Texas over to the Southeast. We started that movement, weeks before the hurricane, or before we actually opened. And then, so by the time that locations were impacted, we then, finalized the decision in terms of where they would go. We had to work through the logistics of where to put the mobile pharmacy. Normally, we put it right in the parking lot of the location that was impacted. In this case, you saw the picture of the parking lot; it was destroyed. There was no way to put a mobile pharmacy there, so we had to find a location nearby that could accommodate that mobile trailer. But in terms of beginning, we started that. We try to start that decision-making process as early as possible. In many cases, when we know a storm is coming.
Thank you. And you, Takashi, what is the experience from Japan in terms of starting a mobile clinic from the decision till you are able to operate? How long time does it take? Oh, you're on mute, Takashi. Perfect.
Established mobile clinic or mobile pharmacy are controlled by headquarters of a disaster headquarters in prefecture. So it coordinated by a DMAT or disaster medical coordinator controlled headquarters. They decided area and role in disaster situation of the mobile clinic and mobile pharmacy.
So how long time was that from they made the decision till you could you were on the
in this Noto Peninsula, in this case of Noto Peninsula, mobile clinic established into the 24 hour.
Wow.
But mobile pharmacy deployed district area is I think so 5 days.
Very fast. Huh?
Yeah.
What is your experience, Marc, in more? Yeah.
Again, it depends.
Yeah, so Japanese mobile pharmacy are very small than
Yes.
the American mobile pharmacy.
I know.
I think we can get equipment, and if we need to set something and send something out, we can do that within a couple of hours or 24 hours. We can have things on the ground. But if you're wanting to set up a regular mobile clinic where you want to visit every week for a year, getting the stock in to supply that could take months. So it's flexible.
Yeah, I know. Unfair question, but yeah. There was more. I also have questions from Daniela. I think it's mostly for Takisa and Jinu. She asked who covers the cost of the dispensed medication?
In the US, it would be, most individuals have insurance companies. So again, the mobile pharmacy would be treated the exact same way as any other pharmacy. So the patient's insurance typically covers it. They might have a copay or co-insurance associated with that from a cost standpoint. In some cases, if patients don't have insurance, they would be self-pay.
Okay, perfect. Let's see. That is a question, but it might be mostly me who should answer that, but I can do that after. There's also a question for you, Takashi. I don't know if you were able to respond to this, but someone asked, I would love to hear more about your experience involved in the emergency response in Gaza.
Gaza, yes.
Yeah.
It is my mission is medical record cleaning. Do you know MDS, minimum data set? Do you know Marc? Minimum data set. It's okay. So in the Gaza, many team activity in Gaza area. They recorded the medical record. Central Japan, we are data cleaning for the WHO weekly report. Yeah, thank you. Is it okay?
Yeah. It's very good. Thank you. And I think I have one last question. I have gone up and down in them. In a crisis-affected regions, how can pharmacists ethical balance between emergency dispensing practice and rational drug use when guidelines and supply chain are disrupted? Yeah. I don't know if you, Takashi, would start and then maybe Marc can come after.
Sorry, I just had a bit of a connection
Okay.
issue. Could you just repeat the question?
I can repeat, yes. The question is, in a crisis-affected region, how can pharmacists ethnically balance between emergency dispensing practice and rational drug use when guidelines and supply chains are disrupted?
I can start with that while I'm here, if that's easier.
Yes.
I mean, in terms of drug quality, that's not often an issue for an organization as big as NSF, because we have pretty good supply lines. As long as we've given good forecasting and a good indication of what we think we'd need, and we have subsequently used it well, we're really careful about drug quality. So I've recently been in Myanmar, similar to Takashi, where we were attempting to make local purchases for various sort of logistical and legal reasons, purchases of items in Thailand. So it's a really thorough process of trying to identify sustainable manufacturers with good manufacturing processes and getting those medications into Myanmar whilst maintaining quality and reducing the risk to the patients. There is often, and I've had this many times, particularly during COVID, where we were running out of a lot of medications that we would use for other illnesses. So we have to change the guidance and guidelines for certain treatments. So, for example, we were using some HIV treatments to treat urinary infections, so things like cotrimoxazole, rerouting those guidance, reapplying those medications for different purposes. So we're trying to, but always doing that with the idea of creating clear, simple instructions so that less qualified medical staff can still simply follow that and get to the same conclusion and allow us to treat patients. And then I think the bottom rung of the ladder sort of arrives when we're kind of very, very limited in what we have, and can we even safely provide the care that we want to? And obviously we're seeing that in places like Gaza at the moment, where they're so limited in what is available to be able to treat people, that people are using things like bedding and T-shirts and things to dress wounds rather than bandages and gauze, because there's simply nothing there. So wherever it's possible, we'll use the highest quality of medication and follow some sort of guidance, whether that's international guidance that we have for most cases and most diseases, tweaking them when we need to. And then obviously in complete emergency situations like we're seeing in the Middle East, then it's just kind of everything goes out of the window and you're just kind of hoping for the best and doing whatever we can to try and save lives with whatever we have available.
Thank you for that reply.
Yeah.
Takashi, you had something?
Okay. I think it is so respect the culture of the affected country. For example, in Myanmar earthquake, monks were treated at the predominant level. Thank you.
Thank you. I have a question maybe for Janoon. It stated here, what kind of health counseling do you tend to provide to patients? Is it mainly around use of their medication and also acute conditions that they may present with in the mobile clinics in these situations?
Yeah, In the U.S., the pharmacy acts as a pharmacy. So pharmacists on site provide all sorts of pharmacy services, and counseling is one of them. So in the U.S., in most states, counseling is optional for patients. The patients decide whether they want the counseling or not based on the prescription. In most cases, it's when a prescription is being written for the first time. If there's a change in therapy, if there's a change in dosage, a lot of times the pharmacist will counsel. But it's the standard counseling requirements that apply to that particular state and the requirements of that state in terms of what the pharmacist will comply with.
Thank you so much. I can see that we are running out of time, and I know there are still some questions unanswered, but we only have 5 minutes left. So I think due to time, we have to stop the question and answer, but we have them in the chat. And Ruben, do you know if it's possible just to reply to the questions not answered already in the chat so people can see them later?
Yes, Pernille. So we can also send them via email to our speakers, and then we can
Perfect.
do that afterwards.
Okay, perfect. So thank you so much to our panelists. It has been so interesting to hear about the mobile clinics from these 3 different aspects. I have learned a lot, and I'm sure all the listeners as well. Yeah, and I think that I don't know if there's something we should add at this point, or otherwise I will just like to say thank you so much to everyone who participated, and thank you for all the questions that you provided. It really helped the discussion, and thank you so much, especially to Takashi, Jinun, and Marc for the very inspiring presentations and answer to all the questions.